Today we shall talk about the testing programs and strategies of the Humphrey Visual Field Analyzer. Standard automated perimetry is the most commonly used mode of visual field examination in glaucoma, other ocular and neurological conditions. It is also referred to as white-on-white perimetry because of the use of a white stimulus on a white background. Broadly, there are two types of testing, Supra Threshold and Threshold. Supra Threshold testing refers to the testing protocol in which a stimulus of large size and intensity that would normally be above threshold value, that is, one that should be seen by any person with reasonably normal vision, is used. This is to determine if there is any abnormally low sensitivity anywhere in the visual field. The only response that is recorded is whether the stimulus is seen or not seen. Since there is no quantification, it can be performed fairly rapidly. Its use today is limited and may be used for screening, initially in inexperienced persons who find it difficult to follow the threshold test and the estimate test for driving licenses. Driving standards in many countries, especially when some field defects are found, require the binocular estimate visual field for functional assessment. It is a Supra Threshold binocular test and includes peripheral points. 120 points are tested across 160 degrees horizontally with a size 3 stimulus and an intensity of 10 decibels. In this test, the central part of the field is more valuable than the periphery. The lower hemisphere is more useful than the upper, and the central 10 degrees is not tested. Threshold testing is what is routinely followed today. Threshold refers to the intensity corresponding to the minimal luminance of the stimulus that is detected at any point 50% of the time in predetermined test locations. So let's say that at this point in the visual field, this stimulus is presented to the patient n number of times. The patient should detect it at least n by 2 times. This threshold is determined at multiple points in the visual field and compared with age-matched standards. In Humphrey perimeters, a Goldman size 3 white stimulus is routinely used against a white background illumination of 31.5 apostils. In order to perform threshold testing, one should choose the testing protocol in order to maximize the information acquired. Choosing a testing protocol involves two parameters, the testing program and the testing strategy. The testing program involves the pattern, extent, location and number of points tested, example 24-2, 30-2, etc. The testing strategy refers to the testing algorithm by which the threshold is determined, example full threshold, sitter, etc. Today we shall restrict ourselves to these testing programs. Many of these testing patterns have two numbers. The first number is the extent of the visual field tested on the temporal side from fixation. The second number indicates whether points on the vertical and horizontal meridians are tested or not. In the -1 programs they are, whereas in the more common -2 programs, points are tested on either side of these axes. So the 30-2 program tests the central 30-degree radius with the fovea as the fixation point. It tests 76 points. The points are equidistant from each other, 6 degrees apart, and the points nearest to the horizontal and vertical meridians are tested 3 degrees away from them. In the 24-2 program, the outer edge points of the 30-2 program are left out. So it tests the central 24-degree radius except nasally, where it tests up to 30 degrees. Here 54 points are tested with the same 6-degree spacing as the 30-2 program. This may be preferable in the elderly as it is faster than the 30-2 program. Also, the peripheral points are not considered for glaucoma. Small paracentral scotomas close to fixation may be missed by the previous two programs. The 10-2 program, which provides a higher resolution, tests 68 points 10 degrees from fixation, contiguous points lying 2 degrees apart. The 10-2 program can determine progression earlier in glaucoma. It is useful in advanced glaucoma, especially to estimate risk of postoperative wipeout phenomenon, in macular disorders such as hydroxychloroquine retinopathy, and in some neurological conditions to detect macular splitting. The 24-2C program is available only in the HFA3 model. In addition to the 54 points of the standard 24-2 program, an additional 10 points are tested in the central 10-degree field for a total of 64 test positions. This was intended to combine the benefits of the 24-2 and the 10-2 for a greater yield in detecting paracentral scotomas and field progression. The Macular Program tests the central 16 points of the 10-2 program and is most useful to determine if the macula is split. It is tested with a size 3 stimulus, and if the sensitivity is too low, a size 5 stimulus is used. Absence of split macula with a size 5 stimulus indicates a better prognosis. The Macular Program is generally used only when the central 5-degree of field remains. Each point is tested twice and the second value is depicted as a second numeral in brackets below the points tested. The nasal step program tests 2 points on either side of the nasal horizontal axis on the 30, 40 and 50-degree meridians and 2 additional points on the 30-degree meridian for a total of 14 points. There is a 60-4 program also for peripheral fields. Full threshold was used prior to the advent of the SITA strategies. In the full threshold program, at each point, a stimulus is presented at an intensity which is expected to be seen by the patient. If this stimulus is not seen, then it is increased in 4 decibel steps till seen, then decreased in smaller steps till not seen, then again raised in still smaller steps till seen again. This final decibel reading is the threshold. This is a bracketing technique also called the staircase method. Alternately, the initial stimulus may be seen and a similar strategy is adopted to determine threshold. Because the full threshold strategy takes a good 15 minutes per eye, the newer strategies that use forecasting or adaptive strategies to determine threshold in a fraction of the time are commonly used nowadays. The most commonly used are the variants of the Swedish interactive threshold algorithm. The SITA standard can be completed in about 50 to 80% of the time taken for the full threshold strategy. The SITA fast and the SITA faster take shorter times. The SITA swap combines the SITA strategy with blue on yellow perimetry, that is the short wavelength automated perimetry, and is only available for the 24-2 program. The new 24-2C that we talked about earlier is used only with the SITA faster strategy.